What I'd like to talk about today is kind of almost hopefully set the scene for some of the rest of the presentations you're going to see and listen to today. I want to talk to you about the 7 steps that I see that people need to take as commissioners using evidence. And so I want to talk to you about these 7 areas, and I will skip through them to give time for Q&A. But basically, I want to talk about assessing needs, redesign of care pathways, looking at how peer review, particularly in primary care, can make a difference to commissioning, looking at an example of how data can change behaviours, talk a little bit about predictive modelling, particularly again in a primary care setting, something that I'm calling nudge commissioning, and then finally, and perhaps most important, safety in terms of evidence. But before I do that, I think just set the scene really. The commissioners who will take on this new challenge, particularly clinicians, taking on the challenge from 2013 to commission healthcare in England for £60 billion, are doing it in a very difficult climate and huge change that you'll have seen this in various journals, evidence about the fact that this is just an incredible, almost perfect storm of demand changing across most of the world. And all of these points, if you can see them, all of them apply to what's going on in the UK. Link that to the massive rise in long-term conditions or chronic disease, and particularly people with more than one chronic disease, particularly when they get to 65 plus, is becoming the key burden of health in the Western world, actually. And people, for any GPs or practice nurses in the room, this is, I suspect, 7 or 8 out of every patients that you see every day will have one form of long-term condition or another. And it's a changing the way that we need to commission services, which in my mind is moving away from a hospital setting and much more into a primary and community care setting. And one of the criteria for being, the key criteria for being a great commissioning organisation, I think are these 5 qualities, these dimensions. This is work done by the Commonwealth Fund. And these scores relate to the US, so ignore the scores, but look at the titles, really. And the Commonwealth Fund have done a huge amount of research over the last 10 years, which basically says if you get these 5 things right, healthy lives, focus on quality, get the access correct, really look at efficiency in the system, and make sure it's equitable, then all those things together create a healthy, high-performing health system. And so commissioners, I think, one of their challenges is to try and find all these 5 factors when they're commissioned for care. Worthwhile reading this report. Actually, this came out early this week. If you can find it by the Commonwealth Fund site. It's mainly about the US, but actually some really interesting comparisons across Europe. And the other reason why this is important is because clinicians who a year ago were maybe playing at the edge of practice-based commissioning, most of you are probably in your practice seeing patients, that's what you were trained for. In 18 months' time, the average clinical commissioning group in England will be running a business which is about just less than £300 million, which actually was the turnover of Lego last year in the UK. And so it's a big business. And it will mean changing approaches, changing attitudes. This isn't just about doing what you do in the practice a bit bigger. This is a whole-scale change, and I think that's one of the big issues that commissioners need to grapple with. Is that this is now going to be a big business about improving care for their population. So back to my 7 steps. It's state the obvious, really, but we need to find the evidence about what's wrong with people in our local populations, and there is huge amounts of data out there that, in my experience, has not been as well used by, for example, PCTs as perhaps it should have been. And I think clinicians are in a great position to use data and to use the information about health needs in their area to make a difference to the population. And this is just one example of data that's available, looking at different, this is circulatory disease. But if you go into some parts of London, for example, you can go right down to almost street by street to see where the different cancer rates are. So you can almost have a commissioning strategy based on small parts of your own towns. In East Lancashire, there are 4 large council estates where the death rate of children that don't reach the age of 1 is as bad as Albania. It's like 4 times the rate compared to the rest of the UK. Now that East Lancashire health system is focusing on that. And so something about using the data to really think carefully about what it is you want to commission is absolutely the fundamental point from anything else I say today. And that means changing the status quo. It isn't just about what people have done in the past, which is I'll have a 2% more here, a little bit less orthopedics, please, a little bit more medicine, or let's try and move a little bit of a dermatology service into the community. This is about starting again and looking absolutely at what's killing people in your population. And what's making people not have healthy long-term lives, and thinking about how you change those services one day at a time. So absolutely needs assessment is crucial, and you can make a difference. So this is an example of Sheffield, where they focused on just some parts of their community where they were really concerned about CVD. And you can see the stats there. They made a massive difference in a short period of time by focusing their effort in some really deprived parts of Sheffield to really turn things around. And that's just one example. There are dozens of other examples, and I'm sure many of you have got them in the room today. But using the data, I think, is the starting point. Second thing is then grasping the fact that some of our care pathways are not as good as they could be. And these are just 3 examples that I've seen across the country, where particularly COPD, actually, I'm thinking of Lincolnshire, some parts of the Midlands, other parts of the Midlands, where people have said, people are ending up in hospital inappropriately. What can we do differently about the way COPD is managed? And they're working with secondary, primary, and in some cases social care to redesign care. And so some of these pathways are now up and running, and you can tweak them. They're 90% there. You could tweak them for your local population in the same way that CHD and stroke, for example, in London and Manchester has been transformed by people working together across secondary and primary care to really think through the pathway so that people who've had a stroke get to the right place quickly and have the right medical intervention. So care pathway redesign is something which people shy away from because it's difficult. And I think that's something we absolutely need to do, and use the evidence of good care pathways to think about what are your priorities locally. And the key attributes there are the fact that I find the best ones are clinically led. They're clinically led by somebody who's passionate about it, and then it's often secondary and primary care working together. So people in secondary care don't feel threatened by this, which is one of the downsides, I think, of practice-based commissioning. Secondary care often felt they were threatened by that. Peer review is the third area, and I've seen some amazing results actually, particularly in primary care, people using evidence and questioning and challenging each other about referrals. So Corby is my favourite example of the moment. They've been reviewing practice by practice all their elective and emergency referrals for last year across the whole of Corby. And in that time, they've reduced elective referrals by 25%. By either referring them to colleagues who've got different skills, or actually not needing to refer at all, or in some cases referring more appropriately. All that's been led and run by the clinicians across the practices in Corby. In Liverpool a couple of years ago, they had a real effort to reduce emergency referrals, again by challenging each other about the way that people, in practice, about the way that people referred in. Nottingham is a good example where they use the data to look at all their cardiology outpatient referrals over a 6-month period. I think it was 6 months. And they looked at what happened after the patient arrived in the outpatient clinic. And over 90% of people referred into the cardiology outpatient, nothing further was done to them. The patient was seen, 10, 15-minute appointment, sent back to the practice. So they're now questioning themselves about the way that they refer and whether they could do things differently if actually there's a very small chance of intervention in the hospital. So they're working with secondary care to think that through. So again, using the data, but actually challenging each other in a way that I think I haven't seen as much as in the past. It's a difficult thing to do when you put data up, looking at colleagues' referral rates. But for my mind, you shine a light on something and you start to improve it. You're not meant to be able to read this, but this is an example of data to change behaviours. This is 3 hospitals. And people think about commissioning as commissioning for big service change, etc. But I think they can also, commissioners can also challenge hospitals to think about the way they're spending money. This is different types of orthopedic joints, as in different suppliers, used in 3 hospitals. Each colour means a different supplier. So we've been in to look at the behaviour and the practice in some places. And if you look at the one on your left, you can see there's a significant variation, different supplies, often because the orthopedic surgeon trained at, say, Thomas's, where they used a certain hip, and then he or she has taken that with him through his career. And so many places are often stocking 25, 30 different types of joints, and that's really inefficient. And particularly when the evidence suggests that maybe you could boil that down to 5 or 6 that are all just as efficient and effective for patients. This is another example. Just again, the colour means there's more variation in terms of different supplies, and that's wasting money because we have to have this in stock. It's also potentially more difficult for theatre nurses to get engaged with, etc. So there's something there about challenging behaviour and saying why we're doing it that way. Difficult decisions, difficult conversations, but worth having, I think. And the benefits for me of all this is that where secondary and primary care work together, I'm sorry this is a US example, but this is just a classic example of where the secondary care and primary care work together to help to solve a problem in secondary care. And the secondary care didn't feel threatened by this. And what we had was reduced hospital admissions 50%, and particularly readmissions is, again, startling data about reducing readmissions by the system working together. And that one of the things I do preach on commissioning is that this is about people working together, using the evidence to make decisions for the local population. Predictive modelling is the fifth area, and this can make, I think, a massive difference to people. This is looking at the people who are most vulnerable in practice in your population who may end up in hospital and doing something about that to actually prevent that now. Now, there are tools out there today that many parts of the country are using to prevent this, but we could be a lot smarter, I think. And it's something about identifying those really vulnerable people. And there's it's things like if you're over 75 and you're on 4 different drugs and you go to a 5th drug, your chance of a fall goes up something to 20-25%. It's a huge leap. And so something about detecting that in the system and then putting in the right intervention earlier so that someone doesn't end up in hospital for 6 weeks. My best example is Torbay. Torbay is often talked about as an integrated care system as a really good example. It's only a small place. It's got 23,000 population. And they did a risk assessment, and they found there's only 81 people, and this is quite an elderly population in Torbay. Only 81 people were really vulnerable and really high risk of going repeatedly into hospital. And so what they did, they put effort into that with social services, local authority, secondary care and primary care, working together, looking at those 81 people to keep them out of hospital, and dramatically changed their lives. And the stats, if you see for Torbay, are just stunning in terms of keeping people out of hospital. When they do go in, they're not in for very long, and people are actually living independently outside hospital is significant. You go just across the border to the next county or next town down from Torbay, using the same hospital. Their lengths of stay are significantly higher. People not being cared for in the same way outside a hospital setting. Torbay, I think, is a leading light in terms of how to do things differently, and led absolutely passionately led by GPs, which again is a key defining point for me. Led by clinicians, but working together as a team. And this makes a massive difference to individuals. So they're really proud of this stat, that in a 2-year period, and if you think about it, quite an elderly population, quite high levels of diabetes, no lower limb amputations at all in that 2-year period, because they are managing people really effectively early. Just across the border, beyond Torbay, numbers are much higher. So it makes a difference to individual lives as well. The 6th area, using evidence, is thinking about getting the population more engaged and getting clinicians engaged who don't want to. And for me, the driving here for this, things like telehealth, where the Department of Health, I started this with the Department of Health. It's the world's largest trial of telehealth, 6,000 patients in a trial, and the results are coming out at Christmas, I understand. And Scoop, the results are very favourable. It basically shows that if you empower people and give them technology at home, simple stuff about blood pressure monitoring, simple sort of blood prick tests for diabetes, really simple things, people improve their health. And it costs pennies rather than pounds. And people feel more engaged and want to do more about their lives. And we've got stories after stories of people who were uncontrolled asthma, uncontrolled diabetes, go onto this pilot program, dramatically change their lives. So one patient at a time. But I think commissioners could make a big difference here by really pushing forward on some of the telehealth. People are much more able to do that. The kit's there, it just hasn't taken off yet. And then the primary care peer support, I call it peer support. It could easily be peer pressure to change behaviour, so change the way that people behave, the same way Corby are doing, for example. But something about putting the data out there across primary care and saying, why are we referring this many, or this few actually? I mean, obviously, too few, it could be an issue as well. So something about questioning and nudging people on to change behaviours, almost one patient at a time. An example of this, I'm not sure how well this sort of figures on here, that this is the use of data to try and get the practice to think differently. So in this example, this is a real practice from about 18 months ago. They had higher levels of CHD than would be expected for their population. They also had higher usage of secondary care than would be expected, and more admissions than would be expected for their population. They were also referring much more complex patients than would be expected. But then they looked then at the medicines being used, and they were much, much lower than expected on the use of relevant medicines. And so what that practice did is that they sat down with secondary care and actually with the PCT at the time to say, well, what are we doing differently here? What can we change in terms of our behaviour? And can we do things that are more preventive so that people don't fall off the scale and end up in hospital? And so nudging those, I think it was 5 or 6 partners, to think differently about the way they behaved, and they started to change that around. So it's something about practice by practice as well. So commissioning isn't just about what goes on in secondary care. And finally, the 2 key things about quality and safety in this is, you think about Darcy and I think he's changed things dramatically actually in terms of our perception about safety. And his 3 dimensions of quality about patient safety, patient experience, which I think is coming up very quickly in society in terms of people having a view, and that is evidence that commissioners should use as well in terms of their commissioning decisions, and then how effective the care is. And I think about this, and I think about VTE, where for years it was known that thousands of people were dying in hospital, VTE, and depending on which stat you believe, somewhere between 18,000 and 25,000 people a year were dying of embolism that didn't have to die from in hospital. And Darcy puts that up front centre, Briz Keogh does as well, and we start to turn things around. The evidence for that was compelling, but we didn't do anything about it because no one made a stand for it. And I think one of the things commissioners need to do is make a stand for patients. 25,000 people potentially in 2009 died of VT in hospital. And you just think, a lot of that was preventable. And we just need to do more as commissioners, I think, using that evidence to challenge people. And for me, that culminates in the way that we respond to mid-staffs. I was called to give evidence at mid-staffs about 2 weeks ago about commissioning nationally. And a very humbling experience, really. And the report is due out at some point before Christmas. But there were hundreds of people potentially there who died when they didn't need to. And there's something about using the evidence, not just of data, but also the evidence of your eyes and your ears as commissioners to test what's going on. And this isn't like the way some PCTs worked, and this isn't meant to be PCT bashing, of going into a hospital once every 3 months to do a performance review and sit in a boardroom with the director of ops. This is about going on the wards, listening to what your patients are telling you, and connecting these things up to think, does that link to the hard data I'm getting? And that means doing that more than once every 3 months. If this was, and people hate when I say this, but if this was Tesco or Marks and Spencer's, they'd be in there every day. If Apple, for example, are in their suppliers every single day, checking what they do. And if you're going to be commissioning, and I'm talking to the clinicians in the room here, if you're going to be commissioning £290 million worth of healthcare for your patients and your population in 15, 16 months' time, don't you want to know there isn't another mid-staffs on your doorstep? And so use the evidence of hard data, but also eyes and ears, and check what patient experience is to really change things. And I'm very optimistic. I'm not necessarily positive about the way the reforms are being enacted, but the principle of involving clinicians at the heart of decision-making for commissioning is absolutely the right thing to do, in my view. And I really believe you can make a massive difference to the health of your local population, and I wish you well. Thank you very much.
Hello, my name is Penelope Jarrett. I'm a GP in South London. I'm not personally involved with commissioning, but you're talking threw up lots of questions for me. I will confine myself to two which are unrelated. One is, I wonder what your review of referral management centres is. There was an attempt to impose one of those on us. We rejected it. And the other was the general problem of financial constraints in the sense of budgets. So a lot of the things that you're suggesting require upfront investment from one budget in order to save in another one, which you may or may not have control over, which we find difficult.
I'm Amar Sharif. I come from Dubai. I really enjoyed your talk. One question. It seems that there's a trend now for GPs to do commissioning and so on in the UK. My question is, are they trained to take such decisions, right from their undergraduate education, beyond that to their postgraduate training and so on? So are GPs trained for being managers? And if not, would you agree with me that such modules should be introduced in their education and training?
So my view on referral management centres, I think they can be really good and really bad. And the really bad ones are the ones that are just used as a postbox to delay referrals, and they had no clinical value at all. And they're just delaying patients being moved into the system and a way of just stopping spending money. They're just terrible. And that's not referral management, that's just referral stopping. A good referral management centre could be one where, and I'm thinking of things like, say, Corby, they wouldn't necessarily call it that, but where there's peer review of referrals and just looking and just questioning about why people are being referred. You need to do it very quickly, so this isn't about delaying emergencies, etc., but you need to do it quickly and challenge, because even though all of GPs work in many practices and there's less and less single-handers these days, and I'm married to a GP, so I need to declare an interest, but the opportunities to actually test with each other what you're doing clinically is surprisingly low, I think, partly because of the way medicine works today, partly because of the way society is. So I think referral management centres can be really good if they help challenge and improve the clinical quality of your referral. They're really bad when they're just used to stop. And that's why they've had a bad name, because they were used to stop and slow down. So I can understand why in your particular area you stopped, you didn't have one, because they've got very negative connotations. Done well there, they can be really excellent as an education tool. Financial constraints, well, I would have put these reforms in 3 years ago when there was more money in. It is difficult in a time when we're at virtually zero growth, virtually. And so it will be difficult. I completely accept that. However, we need to get this in perspective. In England, we'll still be spending £100 billion on healthcare. And that's a small country. So it's a lot of money that we're spending, and there is still and evidence supports this, still waste in the system. So just those examples I gave you of orthopedics, which I just flashed up for the colour and just for the effect, if those hospitals reduced their range of suppliers and still went with a smaller number of supplies, but actually still as efficient, those hospitals alone would save £40 million tomorrow, literally tomorrow, by changing suppliers. So there are things that we can do to save money. Every time a patient gets into A&E and then ends up in hospital overnight for something which could have been avoided, that's probably £1,500, which could have been avoided by either early intervention, interaction in primary care, interaction maybe at A&E rather than sending them through. So things can be done quickly to start to release some of the money. I do accept your point, Madam, though, that for some of the bigger change you need to have double running costs. And that is more difficult in a tighter financial world. But it isn't all doom and gloom, because there's a lot you can do now, and people are doing, to release money to actually invest. But it is more difficult, I accept that. The third point from the gentleman, have clinicians been trained to be commissioners? No. No, absolutely not. Should we include it in education? Yes. However, it's not as black and white as that, I don't think, because it will be an absolute monumental failure, in my view, if we turn clinicians into managers, which I think was part of your question, sir, that will be a complete failure. We want clinicians to be brilliant commissioners and stay clinicians. And so that, for me, means not turning your local clinical commissioning group into another PCT by another name. Otherwise, what's the point of all this turmoil? This is about making a difference. And so what do you do as clinicians fantastically well that others don't? The first one is in general practice. You're seeing 1 million people in practice today. 1 million people. You know more about the health needs of the population today than anyone else in the health system, because you're seeing those people come through your door every day. So you've got a real finger on the pulse about that. Secondly, you're brilliant at managing risk. You're really good at understanding risk and deciding what's appropriate for risk, much better than any managers could be about where services should be, because you know instinctively in your 10-minute appointments, you're making decisions about risk every single day. I'm thinking primary care here. So that's the second thing. Third thing, you tend to stay around. Managers come and go and flip through the system. I know it's slightly more mobile than it used to be, but general practice tends to stay where it is generally. I know it's moving a bit. Therefore, you know the situation, you know the politics, you know the way the local authority works. You're more likely to have links into social care. All those things which you'll need for an integrated care system is you've got that in your fingertips. The fourth thing, I'm nearly finished, honestly.
No, you're fine.
The fourth thing is people believe you. So if I stand up here and it's a blue suit, but if I put a grey suit on and be as an official and say we're changing services in my local A&E, people throw eggs at me and there's all complaints. If we put people up who are clinicians who then talk it through and explain it, people listen to you at least. They might not like it, but at least they'll listen. And I've seen time and time again examples across the UK, across England, where that makes a difference. And I'm working with a large number of GPs at the moment and clinicians, and one of the first questions I get asked is, how can we engage with the public better? And that's a genuine, I think, attempt to say, how can we involve the public and patients in commissioning decisions? Partly because I think the clinicians think it's the right thing to do, but also in 3 or 4 years' time, when we are shifting services from a secondary to a primary care setting, we'll need to have those people with us. And I think GPs are really good at that because they're the most trusted profession in the UK. If you look at the stats time and time again, if you're a GP in the room, you should be really proud of this because you get 90-odd% approval rating, which is higher than any other profession that I've seen. So people believe you. There was a fifth one, but it's gone completely out of my head. Sorry.
That's
Sorry,
okay.
Fiona.
Well, you may remember one. But Gary, I'd just like to challenge that. And I'm a great believer in clinicians leading, and I think it's fantastic. But the business about GPs who are great providers of healthcare and how that might conflict with their role in commissioning, both emotionally and how they view themselves, and also in their skill set. And what do you feel about that potential conflict, and how they can continue to be good providers of care and leading on commissioning?
Let's just accept it. There is a conflict. Let's just not beat around the bush here. If we've got 35,000 GPs in practice who are referring every single day and making decisions about patients every single day, they're providing services in one shape or form or another. And therefore, as commissioners, there will be sometimes strong conflicts. And therefore, we just need to be transparent about it. I think that isn't the reason not to do this. We just need to be really transparent. And actually, there's more chance now in this new system of being cleaner about that than we have in the past. Where in the past, under PBC and other ways, people were still making commissioning decisions, but it wasn't called that. So I just think we've got a chance now to just be really transparent and get over the fact that there will be some issues of conflict. It's just the system we're in. And I just think we need to accept that, but have transparency so we get around that. I'm not an advocate of saying we should have conflicts, but we should be transparent about it.
I think it's absolutely essential that there is more clinical involvement in making decisions around how care is delivered and what care is delivered. But I would completely contest that commissioning is a managerial function and that GPs don't need training. It's population medicine that they need training in. And I would say one of the failures of commissioning is that the commissioning teams have not been trained in population medicine. They need to understand how to do health needs assessment. They need to understand evidence much more rigorously. They need to understand how to interpret data and how to apply that. These are the skills of population medicine. They're not being taught sufficiently in medicine. There was no attempt to train commissioners in that. And the idea that commissioning is a managerial, transactional function, I think, is an error that has pervaded the purchaser-provider split for 20 years. So I think actually there is a need for a lot of training, and that training is both for the clinicians involved now in what is a population function, and also the commissioning support staff, and there's been an abject failure to deliver that training.
If it came across like that, I apologise, because clinicians need to be at the heart of commissioning. Absolutely, I think that's right. But do they need to do all aspects of commissioning which isn't in their skill set? No, you can get other people to do that. That's the point I made about managerial. I don't think recreating a PCT, for example, with highly skilled clinicians doing things that other people could do better is not the right thing to do. So I don't quite agree with your starting point. The rest of it, I think, is very very wise. I think we've not been very good at population health. We've certainly not been good at training people, and that'll be one of the skills we'll need to have in the future. Do we need to get every single clinician in a commissioning group to know that? I don't think we do. I think there needs to be an appreciation of it. But do they all have to know the ins and outs of how to do that? No, I don't think that's the case, because actually that will turn a lot of people off. Because realistically, in any one commissioning group, there may be 10, 15 clinicians who are absolutely doing maybe 2-3 sessions a week on this. The rest of the people will be taking part, not quite passively, but relatively passively, and still in their practices. So I don't want to, what I'm saying is I don't want to turn 35,000 GPs into fully fledged, all singing, all dancing commissioners, because I think there are other people around who can do some of those skills, including making sure we engage much more effectively with public health than we have done in the past. And so I think you and your colleagues, for example, can really plug in and bring those skills to CCGs.